Hello, and thank you for the invitation to talk to your conference about consciousness. I'm sorry I can't be there in real time. I am joining you from Brighton, England. And I'd like to talk to you today about a case of secondary clinical lycanthropy in Huntington's disease. This is a paper published with my collaborator, Dr. Nick Medford, who is a consultant neuropsychiatrist at the South London and Maudsley NHS Foundation Trust. And the result of this collaboration was published last year in Frontiers in Psychiatry, if you would like to find out more about it. I'll start by talking a little bit about Huntington's disease, which is a genetic disease of dominant inheritance. The prevalence is 10 to 15 people per 100,000 population, at least in Europe, but the geographic variability is quite wide. It was described back in the late 19th century by George Huntington, which we see here in this photo. And we know from modern research that it's due to an expanded CAG trinucleotide repeat in the gene that codes for the protein Huntington on chromosome 4. So if we imagine the DNA code in this straight line, this is the CAG sequence that is repeated in the case of Huntington's disease a number of times. The higher the number of repetitions, the more severe the disease. And you can see here, for example, repeated 2 more times. And this repetition adds a string of glutamines to the final protein product. So if this is chromosome 4 and this is the normal sequence of CAG, normally repeated less than 35 times, it gives rise to the normal Huntington protein, which is part of a healthy neuron and seems to contribute to the cytoskeleton, traffic within mitochondria, and so on. In the case of disease, we have in chromosome 4 a large number of CAG repeats from 36 onwards that ends up producing a mutated Huntington protein, which can be toxic in the central nervous system and in particular in neurons of the striatum, leading to neuron degeneration. So the effects of the mutant Huntington protein is that it concentrates in cells in abnormal quantities. It's toxic to the central nervous system cells, especially in cells in the striatum. And although this can be dealt fairly well early in life, gradually these aggregates become too much to deal with. So the toxic quantities of the protein aggregate and lead to neuronal death. Ultimately, this leads to a loss of inhibitory function of the neurotransmitter GABA and increase in the turnover of dopamine, the neurotransmitter that's essential in the normal function of the motor system. The clinical features of Huntington's disease are summarized in a classic triad. You have chorea, dance-like movements of the limbs, especially the upper limbs, subcortical dementia, and a family history of the disease. The onset of the motor symptoms usually emerge in one's 30s and 40s because, as I said earlier, initially the toxic protein can aggregate in smaller amounts that can be dealt with, but not later in life. And Huntington's disease may also come along with substantial cognitive, emotional, and behavioral disturbances before the motor symptoms in the 4th or 5th decade of life. The usual course is one of deterioration over time. Unfortunately, no one improves with this illness, and usually there's death followed within 15 to 25 years of clinical onset. In terms of radiological findings, So on the right, we have a coronal slice of a structural scan of the brain within the skull. And you can see the normal, healthy caudate nuclei, which are part of the striatum. And you can see that they are right adjacent to the lateral ventricles. On the left, you see an MRI of a patient with Huntington's disease, and you can see that the caudate nuclei are not there, they're atrophied, and you have a subsequent enlargement of the lateral ventricles. So this is the hallmark on an MRI scan of someone who suffers from Huntington's disease. Along with this anatomical change, we have early personality change as well as psychiatric symptoms. In terms of cognitive and emotional symptoms, there's high irritability or apathy, social cognitive changes that can start decades before the onset of motor symptoms. The people around the patient find these psychological changes as the most disabling and distressing features of the illness. So they describe the patient turning into quarrelsome, argumentative, stubborn, unfeeling, less empathic, irritable, or aggressive. Theory of mind deficits also have been reported, so an inability of a patient to think about how the other person might be feeling or thinking about a particular problem. And also we have anxiety, psychosis, and affective disorders accompanying Huntington's disease. The particular case I will talk about refers to a 63-year-old white British male. His mother also had Huntington's disease, and she had been diagnosed with the illness at the age of 50, and she died at the age of 60. Now, the patient was asymptomatic for a very long time, so he was quite certain that he didn't carry the gene and he was not going to develop the illness. So at the age of 58, he did a genetic test for peace of mind, believing that it would return negative. But actually, he was a carrier of the disease. The CAG repeats were running up at 41. And approximately 18 months before the patient was admitted to the specialist neuropsychiatry unit, he had been presenting with increasing agitation and anxiety. He had a preoccupation with taboo ideas, which I will discuss in a minute, and he developed a fixed idea that he was becoming a werewolf. He had been put on various antidepressants and antipsychotics. Unfortunately, those did not yield any benefit, and he had eventually to be admitted under the Mental Health Act. He was sectioned because he presented a risk to others, to a general psychiatric unit, and after 2 months he was transferred to the specialist neuropsychiatry unit. So his presentation was that he had intrusive thoughts of defecating in a church or eating human or dog feces, and according to his way of thinking, that would prevent God from dying. He was not able to eat or drink very much at all. Somehow that was associated with fear of eating God, and that led, of course, to dangerous weight loss. He had a preoccupation with the idea of strangling his wife and had put his hands around her neck several times. Somehow he thought that if he killed his wife and ate her, then the cosmos would be realigned and saved. That was presented as a pragmatic solution without any remorse. So there was this range of apocalyptic and transgressive ideas which did not hang together, and the patient himself acknowledged did not hang together. At initial examination, neurologically, the upper limbs presented with almost continual movement, while the lower limbs were difficult for him to keep still. He openly discussed his belief that he was going to turn into a werewolf any minute. He also stated that he was the devil, and there were reports that he was going to die soon due to his organs becoming exposed and that he would then go to hell. However, he denied that he had any hallucinations. In terms of other investigations, there were impairments in his attention, in his memory, and fluency, which, however, normalized as he improved, as I will discuss in a minute. His structural MRI showed that his caudate nuclei were unusually small, which is consistent with diagnosis of Huntington's disease. So you can see in this structural scan, his lateral ventricles are enlarged and the caudate nuclei are atrophied. So in the initial weeks following the admission, he still maintained he was a werewolf. He was very preoccupied with his bowels, either that he was constipated or blocked, and that was somehow relevant to the state of the cosmos. So some of the things he was talking about was that he was just about to die. He was completely blocked. He was going blind. His overall body was shrinking and he was just ahead. There was a distinct perceptual disturbance. For example, he stated that the tablets that he was supposed to be taking were too big, or the needles that they were trying to take, for example, blood samples with were enormous to his eyes. He felt that the needle was larger than his arm. And that at that point, his psychiatrist, Dr. Medford, decided to start him on clozapine, which is not a usual antipsychotic to use in Huntington's disease at all. However, he had run out of options at that stage. So what he noticed was that over time on clozapine, there was a gradual settling of the patient. Interestingly, the movement disorder became much less prominent. So the upper limb movements became much less prominent, as well as the nihilistic apocalyptic ideas became much less prominent. So the patient stated there was still about 50% chance that he was a werewolf, but he was not apparently distressed by this. Over time, he managed to have successful periods of home leave. His section was rescinded. He was no longer a danger to others, and he was eventually discharged to local services. So in terms of lycanthropy in general, we are referring to the phenomenon of conversion of humans into wolves and vice versa. It was described since ancient times. It's a prominent feature in classical mythology and demonology. There was a peak of reports of cases of werewolves in France in the 16th and 17th century, where up to 30,000 cases were reported. In the 19th century, it was described as a delusional belief. We also have reports of partial lycanthropy. So we have delusional beliefs about excessive hair growth and wolf-like appearance, but not complete transformation into a wolf. Now, these are all mostly cases that are not cases of clinical lycanthropy, because in clinical lycanthropy, we have an actual delusion about becoming a wolf or a werewolf. So this is extremely rare, and there have only been 13 cases reported over 162 years. Now, in the case of the patient I described, we believe that we have a case of secondary clinical lycanthropy. So this is a case where the idea that the belief evolves out of somatic hallucinations and changes in one's sense of physical identity. So we have the case of someone who has perceptual aberrations and perceives things differently and changes in their sense of body and sense of physical self. So it's relevant to mention here that the patient had a horror of developing Huntington's disease that was linked to the memories of his mother's illness. He talks about his mother being incarcerated one day when he returned from school, and the eventual deterioration of her condition. So he had an absolute horror and disgust at the idea of developing Huntington's disease. It's also relevant to mention that the caudate nuclei, which we saw are atrophied in the case of Huntington's disease and in the particular patient, they are part of a brain structure called the striatum, which, among other things, is involved in feelings of reward, pleasure, but also aversion to negative stimuli, as well as disgust processing, including moral violations. So we saw how this patient had all these transgressive ideas about defecating in a church or strangling his wife to restore the balance of the universe. So he was not able to understand the moral violations that normally accompany such thoughts, or process disgust in a normal way, potentially because of the atrophy in this part of the brain, the caudate nuclei. So we think that the abnormal perceptions of disgust, as well as self-related disgust, was a contributing element in the development of clinical lycanthropy in this patient. So we believe that the combination of the physical changes that were linked to his disease, for example, losing a lot of weight, growing some more hair, and so on, associated with the sensory misperceptions, the fact, for example, that he thought a needle was longer than his arm, and so on, along with the horror of the disease and the fear of deterioration that he had witnessed with the illness of his own mother, led to the development of clinical lycanthropy. And this is, to the best of our knowledge, the first and only case of clinical lycanthropy developing in a patient with Huntington's disease. It's a delusion that's sometimes associated with schizophrenia, but not with a neurodegenerative disease. And at this point, I would like to thank you for your attention, and I hope you enjoy the rest of the conference. Thank you.